Perfect. Yeah. People trickle in and we're also recording this meeting as people often listen afterwards as well. So hello everyone. Good morning, good afternoon. Thank you so much for joining us for today's monthly speaker series. Really pleased that we have Cybil Roehrenbeck with us, who's going to be speaking about legal and regulatory landscape of healthcare AI technologies today. I'm going to give a brief introduction of Cybil, and then I'll turn it over to her. Cybil Roehrenbeck it serves as the executive director of the AI Healthcare Coalition. She leads legislative and regulatory advocacy efforts for the coalition. She's also a partner at Hogan Lovells and specializes in medical intervention law. She was recognized by Law 360 as a health law MVP in 2022. She also hosts the annual AI Health Law and Policy Summit, and she's previously worked on Capitol Hill as well as for the American Medical Association. Cybil's a graduate of University of Virginia for undergraduate and University of Georgia's School of Law. She currently teaches health policy at American University Washington College of Law. She's also editing a forthcoming treatise on AI health law for the American Bar Association and parents 3 preteen kids and a terrier. I don't know how you do all of that, Cybil. But we are so excited to have you speak with us today. So I'm going to turn it over to you.
Great. Thank you very much. I appreciate that introduction. And when you read it like that, I do think, do I do all that? Yes, I must, probably to get away from the preteens. So we should have a robust discussion today, and I'm going to try to walk through a lot of the issues that come up the most with the members and clients that I work with. And hopefully we'll have some good questions at the end. I'll try to reserve time, about 10 minutes toward the end, for questions or thoughts, but please also put any questions in the chat so we can go back to those as well. I wanted to just give you all a brief landscape of health AI, and hopefully this is not a repeat of things that you're already aware of, but these are sort of shifting and changing, and I think we can expect some significant changes this year, at least on the CMS reimbursement and payment front. But also wanted to talk through some of the CPT editorial panel changes for AI services and coding, as well as the new program that we have through the FDA and CMS to provide temporary coverage for certain AI and other technologies. We have 2 new rules that have come out recently, which really impact any innovator of health AI, both a rule for certified HIT vendors who are utilizing AI in a number of different ways for their products, and then also a new non-discrimination rule that just came out a few weeks ago from the Office of Civil Rights at HHS. Then we'll talk briefly about some things that are coming. So, of course, we've had a lot of White House activity related to AI, but there's also an increasing amount of activity and moving from the listening and learning to the legislating stage in both the House and the Senate, as well as some significant state activity, which I'll flag toward the end of the discussion. So we always like to start off just thinking about coding, like how are healthcare AI services being thought about in a coding context, and that's usually where for people like me, the conversation starts, which of course is long after folks like many on the line have innovated, actually thought about how an AI tool could help a patient, done rigorous clinical trials, and really identified a need for some kind of AI tool that will have a patient benefit that doesn't currently exist. I know in talking with Brittany and the folks at Johns Hopkins in preparation for this, we were trying to identify a term, and I know AI Ready likes to do that on a monthly basis, some kind of term. And one term that we think a lot about is glamour AI. So AI that doesn't really have a clinical or meaningful benefit for patients. And that's something that I think increasingly folks who are thinking about how some of these services should be coded, and whether they should receive payment or coverage under Medicare or other payers are increasingly kind of examining that question of what is glamour AI and what is AI that can actually have a clinical benefit. But when we're thinking about commercializing and trying to get payment from Medicare and other payers, the first place that we usually try to focus is on the coding front. So a few years ago, as part of the September 2021 meeting, the American Medical Association CPT editorial panel did come up with and approve this new appendix for AI medical services and procedures. Now, to be clear, this doesn't apply to typically fully assistive tools that are just running in the background. These codes generally are being sought for actual AI healthcare services. And how we're seeing that play out is really for services that are used as a result of an FDA-approved AI model rather than a fully assistive tool just running in the background. CPT, I think, was getting a lot of applications, and increasingly they've gotten more and more applications for so-called AI medical services that are unique from other services that already have codes as part of the CPT code set. So they did come up with this taxonomy, which has really become a framework for how we're thinking about distinguishing some AI healthcare services from others. And they did come up with these 3 different categories. One is an assistive AI. So that's an AI that would detect some kind of clinically relevant data, but it does not provide an independent diagnosis. It does not provide, a decision. It doesn't even analyze the data. And it would require physician or other qualified healthcare practitioner interpretation or report. So in this taxonomy, they cite some CAD imaging codes as examples of what would be a fully assistive AI. The second category that they determined was an augmentative AI, and this is kind of the hybrid. You could look at these as from assistive to autonomous, taking on greater levels of autonomy. The primary objective of an augmentative AI model would be that it would provide an analysis or quantify clinical data in a meaningful way, but there still would not be an independent diagnosis or management decision rendered, and a physician or qualified health practitioner would still be required to interpret and report on the data. And the example that they gave in the code set there was of a continuous glucose monitoring or CGM code. Lastly, fully autonomous AI. And the one that we think of here as an example, and I know some folks at Johns Hopkins have worked on this as well, is CPT 92229 for the diagnosis of diabetic retinopathy. Working on that is really how I became involved in this work several years ago. So that's where the primary objective is to really interpret the data and independently generate a clinically meaningful conclusion. This type of AI would provide an independent diagnosis or management decision and would not require a physician or other qualified health practitioner interpretation or report. So again, you see in this chart that retinal imaging is referenced there. And actually within this taxonomy, there are a number of different levels within the autonomous category that CPT refers to as well. But this is a good framework for thinking about, CPT is issuing codes for AI healthcare services, and B, within that, we are seeing some distinguishing between the levels of autonomy in the codes. And the verdict is out with respect to how that might translate to how payers view payment or coverage for some of these specific codes. So there was a great article that came out at the end of last year, actually in the New England Journal of Medicine. They've launched an AI subscription, which is fantastic. And so they did go through these authors, and the citation is at the bottom there, and I'm happy to provide it afterward if it's helpful for anyone. But they did give a summary of the CPT codes for AI services that had been cleared heretofore, and this was again from November of last year. So we do have some additional ones since this chart came out. But you can see here some of the early ones that really got going early. So HeartFlow, for example, had 67,000 total claims, and you can see they received a CPT code in 2018. They were the earliest. You can see the 92229 for Luminetics Core, which was previously IDXDR, that's to determine the presence and diagnose diabetic retinopathy. That's the fully autonomous code that's on the code set right now. That was effective 2021 and had 15,000 total claims. And you see a lot of these are in totally different medical specialty areas, which is interesting. So heart flow is the cardiology, ophthalmology for 92229. You see the Perspectum has the liver multi-scan. Optellum is another one. So we're seeing really, even all the way down to Osteo app, a number of different codes that have received a CPT code or some kind of transitional code, and now we're receiving claims that are running through the claim set. So very interesting just to see these things are being paid in some cases, but certainly there are claims flowing for some of these services. From that same study, I wanted to highlight, they just were talking about how medical AI is growing, which makes sense because this is so new. We should expect to see this curve continue to go up and up and up. The most claims were coming from, again, some of the cardiology codes for coronary artery disease or other coronary issues. Also, the liver MR was another one where we saw 1,000 plus total claims, and then also diabetic retinopathy. We also can see claims for breast ultrasound, multi-organ MRI, some ECG and lung CT. So this will continue to shift and change. I think some of these at the top with 1,000 plus total claims were early, but we will see this proliferate around all the medical specialties, particularly any specialty that has any imaging component. We should see more of these claims begin to flow. So just interesting that this is already taking place. A lot of policymakers that we work with through the AI Healthcare Coalition are unaware and surprised, I think, to see how many specialties already have CPT codes for these types of AI services. So how are these getting paid, and are they getting paid? That's the other issue that we think about a lot. We want to make sure that for AI that is clinically meaningful for patients, that they have access to those services and that they are being reimbursed appropriately. And for many of the early innovators and startups with whom we work, Medicare is really the gold standard to achieve payment with Medicare, lends itself to then being able to work with some of the private payers and receive payment under some of those plans. So that's a place where we focus a lot. We have seen payment flow, and I'll talk about that a bit, but in general, advocates really feel, and I think this is pretty universal amongst all the trade associations, that, clear reimbursement pathways are needed. We're essentially trying to take reimbursement methodologies that were set up for largely in-person visit type services, have now been adapted a little bit for telehealth or remote patient monitoring services, but are really not workable for many of the AI services, which are totally different. And so I do think that the folks at the Centers for Medicare and Medicaid Services have been quite creative in their approaches to try to ensure access to some of these different services for patients, but as the volume increases in terms of innovation and how many, really are clearing that FDA breakthrough device determination or are receiving some sort of authorization for FDA, it'll be interesting to see how Medicare keeps up to ensure that some of these things are reimbursed appropriately. As with all healthcare services, we're still working with our old friends, the physician fee schedule, the outpatient prospective payment system, and the inpatient prospective payment system. These are the methodologies that we have available to us. And AI services are covered largely under these under the Medicare benefit categories, and these are the methodologies that we have to work with in terms of receiving appropriate payment. Generally in the PFS, we've seen that AI healthcare services are reimbursed as part of the practice expense methodology. There's been some push back and forth, I'll talk through in a second, about direct versus indirect practice expense, but that's where we're seeing payment flow. In the OPPS, some AI services do have assignment to a clinical ambulatory payment classification, which is how most services are paid under the OPPS. But increasingly, many innovators are seeking a new tech APC type payment, which is, again, was not set up for AI services, but has become a place where some early innovators can receive and seek payment. And then IPPS has a similar type program, which is called a new technology add-on payment program. Again, time limited, non-permanent payment for certain AI services. So I'll walk through those a little bit in more detail now. So with respect to the Medicare physician fee schedule, this is actually a figure that came out of a RAND report that was commissioned by CMS looking at changes and updates to the physician practice expense survey. And they focused there on how AI should be paid for. And they talked about how within this methodology for certain per-click services, which AI innovators don't agree with or like that terminology at all, but for per-click services, where that would be paid for. And generally what we're seeing is that there are no work RVUs for these services. That's been, I think, a red line in terms of the physician organizations to concede that there would be a physician work RVU for any AI service is something that has not happened yet. So that's been interesting and, could evolve over time. With respect to the malpractice RVU, we're seeing some small malpractice RVUs attributed to the payment for some of these services, but the large bulk of payment is really within this practice expense RVU. And there has been some back and forth with CMS. Innovators and advocates have contended that it really should be a direct practice expense, similar to non-physician clinical labor. Because there is a per patient cost to using the AI tool, it is on a per patient basis, unlike an indirect practice expense cost, which is really something that CMS has used for administrative overhead, something like your IT system, annual cost for your IT system, or the rent for your office. That is where CMS has been kind of sticking a lot of these payments, which again is something that I think innovators have tried to really advocate against. You can see here that in the, this is part of the preamble from the calendar year 2023 Medicare Physician Fee Schedule final rule. And in that discussion, CMS talked about how they believe that, AI services would really be better understood as forms of indirect cost, similar to office rent or administrative expenses. And this is a place where we're seeing pushback, I think, from folks that are actually innovating in this area, and where we do anticipate to see additional work this year as part of the annual rulemaking from CMS in all three of these payment methodology, payment system areas. This is another poll just from that RAND report where, CMS is thinking about whether they will view AI services as per click fees. So, essentially pay them at a very low cost, thinking that the innovators can make up the pricing based on a large volume. And again, I think the folks within the innovator community would contend that doing an AI analysis per patient really for each patient encounter, which is unique and oftentimes requires physician oversight, is not the same thing as a per click. This is from 2023, so these are have been updated since for the 2024 payment rates, but just to give you a sense of what some of these payment rates are, they're really all over the place. You can see ophthalmology around $45. For cardiology, we've seen some that are contractor priced. Many codes, even if they receive a national acknowledgement that they should be paid on a national level by Medicare, have then been priced by the Medicare administrative contractors for a period of time, which has again led to a lack of stability, I think, for many of the innovators in this space. But you can see some of those codes are up to $900 for the code. So these are just some examples to give you a sense that the prices really are all over the place, which would make sense because these codes are treating completely different types of medical underlying conditions in different specialty areas. The OPPS, my favorite payment system. So what we're seeing is most AI innovators are seeking a new technology APC rather than a clinical APC for new AI services. That's because the new tech APCs have a unique system where you can apply for them, and they really are, that payment system is really meant to address fully innovative type services. To be eligible, a healthcare AI service or any service, healthcare service that's seeking a new technology APC payment has to be new, so it can't be adequately represented in the claims data that OPPS already has. It can't qualify for additional payment under a different pathway that CMS has for transitional pass-through. It can't be reasonably placed in an existing clinical APC group. It has to fall within the scope of a Medicare benefit category. That's one where we are seeing some work that needs to be done on the front end before these applications go in. And CMS can assign a new technology APC payment for something like 2 to 3 years. The applications occur quarterly. So this is a whole work stream if you're trying to seek an outpatient payment. That we have folks here on our team that this is all that they do, is try to put together these applications and get them submitted. It's really an art and a science. You can see here, similarly, many of these codes that have received OPPS new technology APC assignments. So some radiology codes, gastroenterology codes, ophthalmology codes that have received new tech APCs. And here you can see again, 9229, they actually received an assignment to a clinical APC. One issue that we're seeing for some companies here is that they are, after a couple of years, OPPS will look at the claims data that they have and adjust the APCs up and down. That's true for all services that are in APCs, but for newer innovative technologies, that can be troublesome just because CMS has less claims data. So what we've seen CMS do is allow a little more time to gather the relevant data to ensure that the price is in the appropriate APC. One thing that CMS did that was really notable as part of their 2023 outpatient prospective payment system final rule is acknowledge that for certain software as a service, which is one way that AI is referred to by CMS, for certain SaaS CPT add-on codes, that they would pay separately for them. A lot of these AI codes are considered to be add-on codes. So that was very positive for folks who had codes that had been, deemed add-on codes and really were the SaaS codes, that they're receiving the same payment as the similar code that would be for the in-person, provider or clinician provided service. The IPPS, so we also, similar to the new tech APC and the OPPS payment system, within the inpatient payment system, we have a new technology add-on payment, or an NTAP. The NTAP has different criteria, and generally 3 criteria must be met, although there are some exceptions. The medical service or technology must be new. There's a lot of regulations around what would qualify as new. The medical service or technology must be costly, such that the MSDRG rate can't really cover the cost of the service for the hospital. So that's a whole determination analysis unto itself. And then the medical service or technology must demonstrate a substantial clinical improvement over existing services or technologies. Again, that's a whole regulatory analysis, whether or not an AI service would present a substantial clinical improvement over what is already covered within the MSDRG. Even if you qualify under those 3 criteria, the payment is going to be limited to the lesser of 65% of the cost of the technology, which CMS solicits invoices as part of this process to see how much the hospital is paying for the technology, or 65% of the amount by which the costs of the technology exceed the standard MSDRG payment. So I think CMS is taking a cautious approach here to try to ensure that they're not paying for a lot of services outside the DRG that could just as well be paid for in the DRG payment. But again, this is something which was not conceived to really pay for AI services per se. And so it's a little bit of a round peg in a square hole. If you have received an FDA breakthrough device authorization, you can get, some of these criteria are softened a bit for you, and you may be exempted and have a little bit of an easier path to receive an NTAP. One issue around the NTAP, I'll just show you this. Some of these things, well, here, this just shows that some of these are discontinued after a certain amount of time. So sorry, this slide got a little bit wonky, but you can see some of these actually will be kind of put on the shelf after a while and see. And the one that we think about is the real example of that is for Contact, which was, it's number 7 here on this chart. You can see we do have some services which are successful in receiving the NTAP payment and really jump through all these hoops to show that they are not covered over the DRG. It's a totally new type of service. And then they only get the payment for, a certain 2 or 3 years. And then CMS basically considers these things as included already in the DRG. So one issue that many folks have been advocating around is more permanent pathways post NTAP, post New Tech APC. So you can see here, one of the issues that we have with these payment pathways is a lack of clear, consistent terminology. CMS will refer to AI services as I mentioned before, software as a service. FDA will refer to them as software as a medical device. We see HHS broadly talking about these things as AI. So one recommendation that the AI Healthcare Coalition has had is to align definitions with the AMA CPT appendix, since that's something that the medical community has really coalesced and coordinated around, of these assistive, augmentative, and autonomous kind of categories for AI. Another issue that we hear when thinking about these different payment methodologies is just inconsistent time periods for application and duration. So, yes, the physician fee schedule, OPPS and IPPS are annual rules. So we have some certainty with when those rules typically come out as proposed and when they're finalized. But there are significant differences which make it really tough for innovators. So for example, the New Tech APC is limited to a 2 or 3 year duration. There are quarterly applications for that. The IPPS is an annual process, but it's limited to a 3-year duration. The MAC pricing for physician fee schedules, that's on a different timeline as well. So some of these timeframes are statutory. And again, they weren't set up for AI. So changing them from a statutory perspective, I think could be difficult. But these are some of the struggles that companies have been going through. And stakeholders like the AI Healthcare Coalition have proposed that CMS, to the extent possible, align these time periods, align the criteria, align the application processes. One thing that we've been working on most recently is that, for example, there would be a 5-year minimum duration for a New Tech APC or NTAP. Which could hopefully be helpful. And I think that's something that we could see coming to the fore soon. The verdict is out on that, but that's one place where, at least if we could have a 5-year runway, I think CMS would be able to gather more claims data about how some of these services are being used. And we could see really how much they are able to be incorporated into the DRG afterward in the inpatient setting, or would really require a totally separate payment. Some of these slides are not working well on this. Sorry, these are showing up like this. I'm just gonna work through these. With respect to the executive order, we're pleased to see the executive order that came out recently from the White House, and I'll talk about that a little bit more on a slide that's not messed up. TSET pathway. This is coverage, right? So if you have coding, you have payment, but it's no good if you don't also have coverage for the AI service. So that's a place where we really try to focus as well. Where can we receive coverage? Folks may remember that under the Trump administration, the Medicare coverage of innovative technologies pathway was proposed and sort of almost finalized, and then the Biden administration actually pulled that back when they came in, and they developed their own new pathway, which they've called the Transitional Coverage for Emerging Technologies pathway. The concept behind this is really that CMS and FDA would be working together and in concert as a new technology is sort of going through the FDA process, so that there wouldn't be such a long lag time after something is FDA approved before it's really accessible to patients and commercially available. And to really make that determination about coverage early on, so patients are not waiting, 3, 4, 5 years to receive access to a covered and paid for product. The way that TCET proposes to do that is to do early and voluntary manufacturer engagement with CMS. And, if that engagement goes as planned through the parameters of the pathway, then AI services would receive national coverage for 3 to 5 years. And pending the development of evidence that CMS and FDA would be looking for, but primarily CMS. People were cautiously optimistic when this thing came out until they read like the 4th page where it said that only a small number of medical devices, only maybe 5 per year, would be accepted into this pathway. And I think that's the place where many stakeholders thought, well, this is insufficient. There are going to be way more than 5 per year. If you talk to people that do this all day, every day, I've talked to some of my colleagues and lawyers who actually don't think that number 5 is that far off, given the volume that we've seen so far. But I think that the general policy community, that was the first thing that people kind of jumped on, was that it should be more than 5 that CMS is committing to putting through this pathway. Let me just show you. So basically, the TCET process would begin approximately 1 year prior to receiving your FDA authorization. So this would be, kind of like folks can remember the parallel review pathway. It's kind of like that, but really amplified and augmented between FDA and CMS. One of the things that they would do early on is determine whether the device or the AI model or service would fit within a Medicare statutory benefit category. So I think things like some other diagnostics which are not necessarily covered under the Medicare statute, those things would be out. They also would look at if there was an existing national coverage determination which precluded either precluded or already permitted that such a temporary transitional coverage, those things would be out as well. So they would do some of that review while folks are going through the FDA process. 2 primary advantages that have been identified with this is that you're going to get early feedback from CMS about your clinical evidence, and they really try to help you work through a plan, or in concept, they're helping you work through a plan for developing clinical evidence. The second really primary advantage is that if you were to successfully go through this pathway, you would receive national coverage for 3 to 5 years while evidence is gathered. So it should be something where you would get greater certainty. It's a collaborative process, and then you do come up with kind of this plan that the agencies have signed off on. They have these really lengthy requirements around this evidence development plan. I won't run through all of those, but there is some opportunity there for public comment before it would actually be finalized. And this just gives you another format to look at what this would be. So essentially, during pre-market, there would be FDA and CMS review. They would look at coverage with evidence development or national coverage determinations and propose an NCD. You could come out of it with 3 to 5 years of coverage, which would be fantastic, and perhaps an NCD covering your product. Okay, I'm going to speed up a little bit because I want to make sure we get through our other regulations. So the Office of the National Coordinator at HHS recently put out a really wide sweeping rule for all certified HIT vendors and developers. So these are basically electronic health record vendors, which almost every clinician obviously uses certified HIT to comply with a host of other requirements. This would impose new reporting requirements for them for AI tools that are within the EHR module. So it's called the Health Data Technology Interoperability. This was within the big interoperability rule that came out recently. Some people refer to it as the HTI-1 final rule. And essentially, they came up with this new term called a predictive decision support intervention. Those are AI tools generally, as well as a bunch of other things. But for these purposes, let's just focus on these are the AI tools that would apply to most of the codes that we just discussed, those types of tools. If the HIT developer supplies that as part of their certified HIT, they need to now comply with a whole host of new requirements. They have to make sure that they're providing source attribute information for each of their predictive DSIs. They need to ensure that their risk management practices, they have to address risk analysis, risk mitigation, governance, a whole host of different criteria for each of these AI models. So what does it mean to have supplied one of these things as part of your certified HIT? So ONC did make some changes in the final rule, and they use this term supplied by, and they really clarified that they only meant that to apply to predictive DSI, which would be, really provided as part of the product that the certified HIT developer is offering. So it's not necessarily that there's an AI service that has data that is then being added to the patient's medical record. It's more if this is part of the product that is being offered to customers of what the EHR is offering, that would be within the scope of the rule. And there's some more information here that gives you more detail about that. But essentially, if an entity would have a contract which specifically covers the enablement and the use of the AI technology, that's within the scope. Here's some more information about, if you have an FDA authorized AI system, if it's exempt from the new DSI rule, generally, it's not going to be exempt as a matter of course. The ONC, even though advocates ask them to exempt AI systems that were FDA regulated because the FDA does its own checks around risk mitigation and bias, those things are not necessarily exempted as a matter of course. They were delayed a little bit, these rules, but in general, these things will be coming into effect at the beginning of next year. So if you have an AI tool that you are developing, likely you can expect to hear from customers or anyone who is looking to include those as part of their EHR module. Will be sending out a query with a lot of information that they will need to have on file to provide to users of their certified HIT. Office of Civil Rights, they just dropped a final rule around non-discrimination. This was a huge rule too that was pending for quite a long time. They actually issued the proposed quite a while ago, and Section 1557 is from the Affordable Care Act, and it basically prohibits discrimination on the basis of race, and other attributes for anyone who receives federal financial assistance. And that certainly applies to folks who are receiving payments through the Medicare program. They changed a lot of their clinical decision support regulations to this new term, patient care decision support tools. And within that term, they've included automated and non-automated tools and expressly AI tools that are utilized by healthcare providers. This final rule will be coming into effect very soon. And under this, covered providers have an ongoing responsibility to ensure that they are not utilizing any decision support tools or AI services that could have a discriminatory effect. So, what we've seen is that many folks on the Hill have been really interested in kind of this rule and what the impact of it would be. And I think that HHS has really tried to take a strong stance here to ensure that providers are ultimately responsible for the discriminatory effects of the tools. From an advocacy perspective, some of the criticism of this has just been that There are already requirements around non-discrimination and bias mitigation enforced by the FDA. Providers ultimately should be able to rely upon the FDA's conclusions about safety, and should not be liable for discriminatory effect of a tool that they might be taking off the shelf. So that is sort of an open question. Many developers, particularly those who have fully autonomous AI applications, have taken the position that the innovator, developer, vendor will take full liability for the use of the tool, as long as the provider is utilizing it consistent with the indications for use. So this is a place where we could see continued discussion. But for now, I think this was a pretty strong statement out of HHS. White House activity. So we do, as folks are, I'm sure on this call, all aware, we did have this executive order come out about AI, and it was quite broad. But what we've seen is rules like the two I just mentioned for ONC rule for certified HIT developers and the Section 1557 non-discrimination and rule, those were sort of teed up. And when the executive order came out, those were directly responsive when they were finalized in the Federal Register to the White House executive order on AI. We also expect more activity. So the Department of Commerce is working away on new standards. We also have seen a lot come out of OMB. Just to give you a sense, in addition to the blueprint for an AI Bill of Rights, we've also seen NIST do a lot of work around a risk management framework for AI. The FTC is working away on guidance documents which could impact healthcare AI applications. EEOCs, they're doing some work which I think is corresponds well to the Section 1557 non-discrimination rule, and others. So that is all the agencies are kind of working away on their own agency-wide AI rules. If you guys missed this, the OMB AI final guidance, this came out and was quite interesting. They talked about safety impacting AI and rights impacting AI. This is the White House Office of Management and Budget. Healthcare was both of these, safety impacting and rights impacting. So that's sort of the highest level of an industry area where we could see concern from the federal government related to AI tools. And so we see a number of different health indications kind of included under these types of AI, which OMB is really suggesting for agencies that utilize AI as part of their programs, that they have a higher level of reporting and risk mitigation and governance related to these safety impacting and rights impacting AI applications. Just in terms of FDA agency activity or administrative activity, just wanted to flag that the FDA did recently release a white paper on its work around AI. There were not a lot of deep details in there, but it was, I think, helpful that there was a lot of input from stakeholders and a lot of good references in there. And FDA also just updated, I think last week, the number they have a running list of all the AI applications that they've given an authorization for. They just updated that last week. So that's another interesting thing to look at. There were in the many hundreds. Congressional activity. We are seeing a lot of work out of the House and Senate. The US Congress has multiple efforts underway, including from the House AI Task Force, which was just recently kind of convened with Mr. Orbanotti and Mr. Liu. The Senate AI Caucus, which are Senator Heinrichs and, sorry, the name is missing there, but Mike Rounds from South Dakota. And then the AI Insight Forum, which Majority Leader Chuck Schumer leads with a number of these other offices, Heinrich, Rounds, and Senator Young. They just released their big paper last week as well. So I think the Senate and House have been kind of taking this view of, we're going to learn what we can about this before we legislate. And then move on to actually drafting legislation or thinking about frameworks for how we want to do this. And that's like swiftly changing. I think seeing the Senate paper come out, I believe it was just last week, that's a big sea change. And so we can now, I think we'll begin to see people put pen to paper on specific changes. And it looks like, although the priority issues for congressional action are, really the elections and questions around AI deepfakes and online privacy and generative large language models, we still are beginning to see legislation drafted specific to health around issues that are really grainy, like reimbursement and coverage. So that's a place where I think we'll see continued activity. This was just an advocacy initiative. We recently were really pleased to help the Senate AI caucus do a panel with a number of folks from Hologic and iRhythm and I believe the other health system was Mount Sinai. I have to double check that, but to talk about some of these issues. And typically for some of these briefings, we're really pushing to get staff in the room. And this one was like an overflow. So that was great and hosted by the Senate AI caucus. Dr. Barra recently also released a request for information regarding AI and health issues, and he sits on the AI House AI task force. So again, we expect to see more activity coming out of the House side as well. On the states, we are seeing a lot, and actually something was just finalized, I believe, in Colorado in the last couple days, but wanted to flag in California, we're seeing a lot around kind of privacy issues and focus on large scale AI models. So we expect state law to be kind of the next frontier, and more states are looking at how AI could impact a number of different industries. What we haven't seen as much is how is AI integrated into state laws concerning the practice of medicine, which is something that I think is going to be, personally for me, pretty interesting and fun to watch, but that's going to be a whole nother like battlefield, I think, in terms of getting access for some of these things for patients. Wanted to just mention, these are the key themes that we're seeing in terms of law and regulation for healthcare AI. This could be really for any industry, but certainly these are top of mind in health. So we're seeing a lot of focus on traceability, a lot of focus on transparency, and I think increasingly acknowledgement that that's not an easy topic to really regulate around. Non-discrimination, as we just discussed. Liability, we expect that there will be a lot more kind of in the case law coming out on liability in the next several years. Human oversight, there is, I think, tension around how much human oversight is going to be required moving forward, and what could this mean in terms of expanding and addressing some of our healthcare workforce shortages, which certainly many providers are experiencing. Ownership, who owns the data? Are we going to have a Henrietta Lacks type situation where people are sort of feeding into the data, or should they get remuneration back? Data integrity, who ensures that the data is good? If you have garbage data going into the algorithm, you're going to have dark garbage data coming back out. And then monitoring, how do we ensure that for some of these models that they continue to have appropriate oversight? FDA has done a lot of good work in that space, particularly with a predetermined change control program that they've developed to ensure that those devices and algorithms that they've already approved continue to have appropriate oversight. But what does that look like in terms of payment or coverage? How do we monitor to make sure that we are not enabling glamour AI, but rather offering to patients AI that is clinically meaningful and can have a positive benefit that we see in patient health outcome. So I will stop there and see if folks have any questions.
Cybil, thank you so much. Wow, you took us on quite a journey.
Yeah.
Really so interesting to hear all this and to think about possibly what changes to the landscape may come with the upcoming elections in November, which I did want to ask you about, but I want to open it up to see if anybody else has a question first. We actually do have 2 questions in the chat as well. I know we have a hard stop at 4 o'clock Eastern time, but anybody feel free to unmute yourself or raise your hand if you want to ask a question. So, well, maybe if you could take your slides down so then we can see.
Yeah, I'm trying to, sorry.
No, not a problem. Any questions anybody want to shout out?
maybe we could start with the two that are in the chat.
Sure. Actually, maybe we can start with the one that I have and then we'll move to the chat, Cybil.
Okay.
What do you anticipate the upcoming election and possible changes as a result of that election having on any of these things? Both in terms of what the stuff that you highlighted as initiatives out of the White House or out of Congress.
The popular wisdom right now, which might be unpopular, is that both chambers will flip. So we could have a Republican-controlled Senate and a Democrat-controlled House, which would net neutral kind of, I think, for where we are right now. So I think that members are going to get more educated on these issues, and that it's going to be a place of bipartisan agreement, one of the few places, particularly in healthcare. And so I think we'll see a lot more, robust legislation coming out of the House and Senate, and perhaps accompanying changes that are already anticipated related to Medicare Part B and sort of some of the value-based payment and annual updates that we have issues for physicians and issues around the conversion factor. I could see some of this digital health, particularly AI, folded into moving legislation related to that. We also are going to could get pulled into, particularly if it's a Republican-controlled Senate, some of the concern around international use of American data. So I don't know if folks are following the Biosecure Act that's kind of charging through Congress right now, concern around Chinese use of American data. I think there could be some AI-related legislation there. In terms of the administration, the thought is that if it remains a Democrat led, Democrat president, we would have increased work and administrative activity, executive activity around non-discrimination and bias, and really focusing on those issues and oversight. Whereas if it's a Republican executive, the president, we think that it would likely be more open doors in terms of payment and coverage and access and changes around the coverage determination system, so that more of these companies can find, commercially reasonable pathways.
Wonderful, thank you. And then we'll start with the questions in the chat. One was, could you describe the process of getting AI-assisted platform or device FDA approved and getting the CPT code? What is the usual time frame?
It takes a while, I would say. So the FDA piece, FDA is, and I'm not an FDA attorney, although I work with many. The FDA is approaching these through the regular kind of specialty areas. So you would be working with clinicians who look at, for example, if you had something in cardiology, who are looking at all different types of cardiology medical devices, would be the ones looking at this same type of service. So you're working with clinicians and regulatory experts in your medical specialty area. People have been generally, in my experience, quite pleased that the FDA has done a great job working with companies and trying to help them navigate some of the more novel issues and approach these services really as healthcare services, and come up with innovative ways, such as as I mentioned, the predetermined change control program and the breakthrough pathway to really enable authorization for some of these things. So that seems to be a very positive process, but FDA can be lengthy. CPT process, many folks are looking for, before they get a Category 1 code, they're applying for a Category 3 code. And typically you would engage with CMS for several months, would be the way that I would advise in terms of getting their feedback on an application prior to actually, applying and going before the panel to receive a Category 3 code. And you really want to work closely again with your medical specialty society and not kind of go it alone with throwing in a application. After you get a code, it can be a while before you receive payment as well. So I would say for the CPT process, I would give it probably about a year would be the time frame, if not longer.
Great. And then there was a question related to your discussion about the executive order on AI and mentioning that there were some definitions for language used in AI spaces. The question was, are there any other government documents that can assist in this effort of standardizing some of the language around AI? Can the ACD on AI help in ascertaining this?
Possibly. I think we're seeing a lot of different definitions, and part of that is because I think the people at HHS are trying really hard to, enable patient access, and they're working with the definitions that they have. And we're working on a legacy system with a lot of historic terms for different things. But as we move forward, it will be important not only to come up with like terms that actually encapsulate what we're talking about, but to really distinguish. Because oftentimes we're saying AI, it's like, well, what does that really mean? What are you actually talking about? And within health, we have a whole set of AI tools that are actually FDA authorized, in many cases viewed as medical devices or software medical devices. And then we have a whole nother group of AI tools which are not going through FDA approval, which are really administrative in nature, but still can have a patient impact. Even distinguishing between those that really clear line, I think many folks that we work with on the policy side, it's not clear, right? Which is which. And then within each of those, there's all different gradations in terms of autonomy and risk. So I think, yes, any document that we can try to use to make it more clear so that people can have the conversation, but a common set of definitions really is kind of foundational to that.
Well, Cybil, again, this was really informative. Thank you for all the great work that you've done in this area, and thank you for sharing all these important lessons with us today. Thanks to all of our attendees. Please don't forget, there is a survey to fill out afterwards. Give feedback on this session, give ideas for future speakers in the monthly series. And with that, I hope you all have a good afternoon.
Thank you.
Thank you.
Thanks very much.